Hi, I'm Isaac Schumacher. I'm a 2023 MD candidate, and today I'm going to talk to you about the anatomy of a capnograph. A normal capnograph starts out at a baseline of 0 with a horizontal plateau that represents the expiration of dead space. As soon as there's a mix-in of alveolar gas, we see a vertical rise. After that, there's a horizontal plateau during the expiration of pure alveolar gas. Finally, there's a maximal point where we get our end-tidal CO2 value, and then it drops off at inspiration. In this capnograph, we see a spike at the end of expiration. This could be the result of poorly compliant lungs in patients who are obese or pregnant. At the end of expiration, the alveoli collapse, and there's a little bit of extra CO2 squeezed out of the airways, which results in that spike that we see. In this graph, we have the exact opposite, with downward slant resulting from excessively compliant lungs. At the start, there's a rapid diffusion of gas, which results in the peak value that we see. But at a certain point, there's a reversal of flow from the low concentrated ventilator tubing back to the patient, which results in dilution over time. Don't confuse this with a ventilator setup that supplies gas right next to the sampling site. Whenever we see multiphasic waveforms, we should consider that different zones in the lungs are emptying at different times, or that there's a leak somewhere. Consider situations like right mainstem bronchus intubation, or kyphoscoliosis or lung transplants. In this situation, when we see a triphasic waveform, there's a cracked water trap. Ultimately, it's important to remember that the better we know our equipment, the better we can diagnose patient pathologies.